Good afternoon. After a long journey of intervention cardiology, my topic is a little bit different. Actually, we have tremendously developed in our patient management, particularly cardiovascular disease, since few decades. This paper published in New England Journal of Medicine by Brunwald and his colleagues, it is found that in 1950, the annual mortality of 450 of 100,000 patients. And in 2010, it became decline around 150 over 100,000 patients due to tremendous advancement of different technology, patient care, like bypass, PCI, ICD, statin, and other techniques. Despite all efforts, still, the death from cardiovascular disease is the leading cause. That 1 in 3 patients died from cardiovascular disease. So what is the reason behind this? Let us look and try to find out the philosophy. There are 4 modern studies conducted recently, and especially CARDES trial, ischemia, BARI 2D, and FAME2, they showed that there is no improvement in death or MI in any of these trials. So what is the reason behind this? We know the coronary artery disease is a disease of wall, not disease of lumen. So many of the cases who are non-obstructive, they usually missed by the stress test. This is the CAG showing mild stenosis, but CT showing there is different plaque, significant plaque. So let's look back at the evolution of the plaque formation. This is the white bar showing the lumen, blue bar showing the wall. When plaque is deposited in the wall, usually luminal area is not compromised until more than 40% of the internal elastic lamina is destructed and occupied by the plaque. So in that time, if you do angiogram, you will see the just normal luminogram with the large accumulation of plaque. At that time, if ACS occurred, this is the most common form of ACS, especially STEMI, young patient, where spontaneous lysis may occur, and there is almost minimum stenosis. So we know the pathophysiology of acute myocardial infarction, especially STEMI. It is the autopsy show that this plaque rupture is the main cause of acute myocardial infarction. Besides the plaque rupture, we know the plaque erosion, which is more common in the young person, smoker, especially female, and some cases with calcified nodule causing the turbulence of the flow, activating the platelets, causing acute myocardial infarction. So which plaque is prone to rupture? It is found that thin cap fibroathoroma is the precursor lesion that ruptured. So thin cap, I mean, it is found in OCT study that the cap, which is 65 micron and containing the large lipid core, they are prone to rupture. So there are 5 main types of plaque morphology, mainly fibrotic, fibrocalcific, and pathological intima thickening. These are the stable plaque. And fibroathoroma plaques are the vulnerable plaque. Among them, thin cap fibroathoroma, which we can detect by virtual histology or hybrid IVAS. I mean, radio frequency IVAS can detect this. So there are studies showing that if the patient has thin cap fibroathoroma and plaque burden more than 70%, their hazard ratio of 10. And if the thick cap fibroathoroma with plaque burden more than 70%, hazard ratio of 5. And so these patients are more vulnerable than stable plaque, which is less than 5% of acute MI or sudden cardiac death. So vulnerable plaque is like an inactive volcano. Look at the panel of the left side. There's angiogram showing mild stenosis, but CT angiogram showing there is extensive positive remodeling. And sagittal section of the plaque showing there is a white necrotic core containing the cholesterol covered by a thin cap, just like a volcano, When it becomes active by inflammation, they become ruptured. And we know that 80% of deadly MI occurs in non-stenotic plaque. So non-obstructive plaque and events, there are different registry. In confirmed registry, there are 23,000 patients, 12 centers, 6 countries, follow-up 2.1 year. It is found that patients with non-obstructive plaque died as often as patients with coronary disease. And another trial, PROMISE trial, where 4,500 patients undergo CTA and 4,600 patients undergo functional testing, and it is follow-up for the 26 months. And this also found that in CT angiogram findings, 77% of cardiovascular death and MI occurred in patients with non-obstructive disease. And there is also total plaque burden is the independent predictor of acute coronary syndrome. So 4 segments or more involvement of the plaque is independent predictor for the acute coronary syndrome. So there is a triangle of risk. We know plaque burden and activity of the plaque and prothrombotic milieu. 3 things are very important for the occurrence of acute MI. So tendency to plaque rupture mostly depends on plaque burden, type of the plaque, and the activity of the plaque. So CTA is the only non-invasive modality that can find the eventual culprit non-obstructive plaque. So how prevalent is non-obstructive plaque in our community? There is no national registry. It is found in SCAPI study in Sweden. They done 30,000 patients of 50 to 64 years, both male and female. Those who have no history of coronary event, 25,000 undergone CT angiogram, and it is found that atherosclerosis plaque is found in 42% of the population. And extensive atherosclerosis is noted in 13%. And obstructive disease was found in 5%. This is my personal clinic practice. Last year, I have done 500 CT angiogram, around 50 years with chest symptom. It is found that atherosclerotic plaque is noted in 59%. Among the non-obstructive plaque is 25%, and obstructive plaque is 34%. So we have to think beyond stenosis. So how can we detect coronary plaque? There are different modalities in our hands. Mostly invasive studies are done, especially by interventional cardiologists, look at for the plaque burden, lipid core, cap thickness, and macrophage. There are non-invasive studies, like CT can identify the key points like lumen area, vessel area, plaque burden, lipid content. And intravascular imaging definitely is better imaging because of better signal noise ratio, because transducer is close to the plaque. There are 4 FDA approved intravascular study. These are grayscale IVAS, radiofrequency IVAS, OCT, and near infrared spectroscopy. Near spectroscopy mainly found the lipid content of the plaque. Among the non-invasive imaging, CT is the most robust technique. Beyond the CT, MRI with or without contrast, nuclear imaging like SPECT, PET, and molecular NIRF can detect in research purposes for the research of plaque. So usually in our practice, CT is done to rule out the obstructive coronary disease. Beyond the stenosis detection, we can assess plaque assessment. Actually, it is low radiation and low cost. This is one of my patients 2 days back. This is the normal CT angiogram of a patient with mild calcification of the proximal LAD. So CT can assess the plaque both quantitatively and qualitatively. Quantitatively means presence, yes or no, what is the location, how much is extent, what is the volume, what is the area, and what is the remodeling index. And qualitatively, what is the composition, whether it is mixed, calcified or non-calcified, what is the CT attenuation, CT density, whether it is a necrotic plaque or not, and the plaque inflammation. So there are 4 important markers for high-risk plaque. 4. One is positive remodeling, another is low attenuation plaque, and another is spotty calcification and napkin ring sign. This is the patient of showing that angiogram, there's mild stenosis in the left main LAD, but there's all the four features present in the CT angiogram. So this patient is very much vulnerable to develop MI with couple of years. And what is the CT appearance of TICFA? Just 1 minute, I'll close. When we know CT has a limited spatial resolution, but good specificity. When multiple features are present, I mean positive demodeling and low attention plaque, this is the napkin ring sign, which is equivalent to the TICFA, which is found in OCT. So I'm going to just... This is one of my patients. Yesterday I have done it. This patient present with anterior hypokinesia, chest pain, and there is a positive remodeling of spotty calcification. And in the LAD and RCA, there is diffuse positive remodeling. So vulnerable plaques are not mild. They are severe. They just look like mild angiographically. Stop relying on the angiogram. So my take-home message is, yes, CT can identify high-risk plaque features beyond stenosis, and high-risk plaque feature predict increased coronary event risk independent of significant stenosis. Higher plaque volume predicts higher event risk. Plaque progression is also a strong predictor of coronary risk. Do not ignore non-obstructive plaque angiographically. Thanks for your attention.